Okay, I see on my watch it's 12:30. So happy to start this webinar. My name is Diederik Arendonk, for some of you known as the coordinator of the European Forum for Primary Care. So the host of this webinar. We have a series of webinars all on this kind of subjects on community care in relation to health inequities. I'm very glad to have this webinar and together with a couple of other webinars this month. Before starting on that, you see the announcement of our European Forum for Primary Care next conference in Ljubljana in Slovenia this year in September. Of course, we do have these other webinars still in 2023. So on the 7th of December, a colleague of Maria van der Muizenberg, our chair, Eric Bischoff, who's going to talk about towards the more person-centered and integrated chronic care approach for everyone. And then later on in December, on the 14th, we have you and EFPC, so the young primary care professionals within EFPC, that present navigating challenges of the young health professionals, empowering the next generation with experiences from Kenya, Kazakhstan, and the UK. So having said that, I think we should start with the webinar of today, which is our colleague Veerle Vyncke from Ghent University, but also working for the Vereniging van Wijkgezondheidscentra. That's always nice to pronounce because I think it's one of the most difficult words, sentences in Dutch language or Flemish language. But she's going to talk about interprofessional collaboration to tackle health inequities. Veerle is also one of our advisory board members on behalf of the community health centers in Flanders and on behalf of the University of Ghent. So Veerle, talk from out of your experiences, an occupational therapist, somebody who wants to have more collaboration at primary care and to tackle health inequities. The floor is yours.
Thank you very much, Diederik, also for the introduction, for the invitation to give this webinar. I can talk about a topic that I'm very passionate about, so that's always a pleasure, I would say. A little bit about myself. Diederik said I'm trained as an occupational therapist. I have to admit that I'm no longer, I would say, I have never been active as an occupational therapist after my training. I've always worked in a university setting, and now in our association, we are guiding primary care practices. So I'm more in a helicopter view, talking a lot with practitioners, but I myself, I'm more someone of theory maybe and the general overview. But I'll use this to share quite some practice experiences with you. So a little bit more about our organization, the most beautiful word in Dutch language, according to Diederik. We're a quite small organization. I'm here with 6 colleagues. Translated, our name is the Federation of Community Health Centers. What we as colleagues do is to give support to primary care practices, to also lobby for them on our federal government level, for instance, to support the existence of new primary care practice. And at this point, we have 37 members, so primary care practices, all working interprofessionally. You see here a little bit an overview. All of our practices are based in the northern part of the country. So they're all Dutch-speaking centers in Flanders and Brussels. There's quite some variety between these centers. However, there's also a big common point, which is relevant to talk about in the beginning. I'll take some time to talk about the context so that you also understand where these examples come from. A big common point that our centers all have is specific financing system. And if I say specific, very specific for the Belgian context. In the Belgian context, there's 220 primary care practices that are based through a capitation finance system, and I'll talk a little bit more into that. So all our centers are what is called by our government level a medical house, meaning they give primary care and they are financed through what we call a needs-based capitation financing system. I said this is a little bit rare in Belgium. Of all the Belgian people, more than 95% are taken care for in a fee-for-service system. This is a system that's for us the most common. Every time you go to a doctor, a nurse, you pay some amount per visit. However, a capitation system works very differently. And I'll try to illustrate this. Capitation system means that you get a monthly sum per patient that is inscribed in your center. So every month you get the same amount per patient, disregarding whether this patient doesn't come to visit you or comes to visit you every day of the month. You have one fixed income as a center. We have this way of financing in Belgium for 3 different disciplines. They're listed here: general practice, physiotherapist, nurse. What's important to know, I won't go in a lot of detail about this financing system. I could do, but it's not the topic of today. But it's important to note that this, specifically in our context, comes with 0 co-payment for the patient. That means that patients don't pay for the services they get in our centers, making it a fairly accessible system, of course. What's also important to note, other professionals can be part of our team. They're just financed in a different way. So important to know, I think. You also heard me say it's a need-based capitation system. What you see here are the general prices that we receive per patient per month. However, the sum that you receive can be very different according to your patient population. In general, centers that take care of a more old patient population or a very socially deprived patient population with a lot of chronic diseases, for instance, will receive higher sums per month. It can also be quite lower than this mean. So I said we have a system of financing that's similar for all centers, but if I'm in my helicopter view, I look at our sector, there's a lot of variability. And in a lot of ways, our centers go from quite small, about 1,300 patients, to what is for us already quite big, 6,000. What's also quite different is the kind of patients that they have. In general, you see here, I took some numbers, the percentage of increased reimbursement, which is in Belgian proxy, you could say, for social vulnerability, is above the mean in our country. So we serve, in average, more deprived patients than other primary care practices. However, also there you see quite some variability between the centers. If you look at age, what's striking is that most of our centers mainly have a younger population. Just to give an idea what kind of patients usually come in our door. We have variability, but again, similarity as well. All the members that inscribe with us, we're not a funded organization. We just exist because people pay us for our support and services. They all subscribe a mission that we all share, which is, you see it here, to contribute to accessible care, for instance, but also to take really action to try to tackle health inequity. So this idea of health inequity is very important for us as an organization. This could be a moment that it's time for some questions. I don't know if something came up, Diederik. It was already a short part, but I don't know if there's already some things.
No, not yet. So it's an invitation. If you have questions, remarks, please do not wait till the end, because we will be able to involve you in the webinar to get it interactive. But for now, no questions. So please continue, Veerle.
Okay, I will do that. Before I dive into practice, how does it look in our different centers? I'll take a short time to look at this concept of health inequity. I said very essential for us as an organization and really a mission for our centers to deal with this. I'm going to assume that some people have no knowledge about the concept of health inequity, so I'll take some time. If you look at data from Belgium, and you would look at 3 men of 25 with a different educational level, you would see that there is, and I'll make it go a little bit faster, that there's a difference of about 6 years between the most lowly educated person to the most highly educated person. In general, in developed countries, we see between 5 and 10% of life expectancy between the lowest educated and highest educated people. What you see further, and this is illustrated in this figure, is that this gap is even bigger if you look at healthy life expectancy. The graph here shows exactly the same numbers as the one I illustrated in the picture. This is the green bars, but the orange bars show the life expectancy you can have without chronic conditions. If you look at this interpretation of healthy life expectancy, the gap is even bigger. It can go until 15, 20 years for most developed countries. So it's very clear that there's a link between social position of patients, of people, and therefore patients, and that there's a big, what we call gap in health. However, what we also see, and which is very evident in this figure, is that there's something that's called the social gradient. It's very important to know that this link between social conditions and health is not only restricted to people that are in very vulnerable situations with a very low income, a very low educational level. Throughout the social ladder, you always see a link between social circumstances, social vulnerability, and health, life expectancy. You see more chronic conditions. There's a very clear link. This idea of social gradient, I stress again, is important because sometimes people think this is really for very deprived people. No, it's not. There's really an important issue to look at the whole spectrum of society, to be aware of the link between socioeconomic factors and health. And what's furthermore worrying, I would say, is that this is different to just health differences. This is different to the fact, for instance, that people that are younger usually have less chronic conditions than people that are older. This is a health inequality, a health difference that's merely contributed to, for instance, a biological process. It's something that is not avoidable by how we deal with our society. There's no sense of unjust unfairness. Health inequity, what we just saw in this graph, is something else. There's a link to how we organize our society, about societal processes that define the health chances of patients. And this is important for us to know as care providers because it gives us a mission, I would say, to also be aware of that. So health inequity, what I talk about today, is really these difference between people that are linked to social processes, which are avoidable also and unfair and unjust. If we look in literature as to why we see this, why is there such a clear link between socioeconomic status and health? Different things come up. The first one I want to stress is very fundamental, and I talked about how we deal with our society. Our society is uneven. There is processes of discrimination, social exclusion. This for sure plays. Literature calls this the cause of causes. Things like poverty, you're discriminated against, excluded. What you also see is that experiencing illness and disease can lead to exclusion of the job market, for instance, and therefore lead to higher chances of poverty. It could lead to lesser chances to get a degree, for instance. So in Dutch, we sometimes say sick makes poor. This is a little bit an easy way to say, indeed, experiencing illness and disease can lead to more chances of socioeconomic vulnerability. But what we also see is vice versa. The socioeconomic circumstances of every person have a link, direct link to their health. And what we see in people that are living in a more vulnerable position in terms of socioeconomic status, that they have bigger chances of experiencing unhealthy behavior, ill health, because they experience more health threats. And I'll try to illustrate this with one of my favorite models. This comes in the next slide. I'll just skip over this one. Maybe I'll go back to it because this is for me the main point. Which happens there, and which is very important, literature shows, is the importance of social determinants of health. Your socioeconomic status will predict how the social determinants of health will in fact impact your health. And I'll try to make this more specific. This is a very basic model to look at what describes the health of people. There's a small portion in the middle that's not changeable by our health system, by care providers, age, sex, hereditary factors. You could say who you are. There's layers around it that are much more changeable and that are highly influenced by socioeconomic status. These are your lifestyle factors, what you do, but also the circumstances in which you live, in which you age, in which you work. More in detail here in the figure. What we see with people that are in a more vulnerable position is that all these layers at a certain point in time will entail more health risk factors, more things that are not so sustainable for good health and long life. And that usually throughout their life also they experience more risks at these social determinants of health. What do we also see is that as care providers, we're not always very well trained in being aware of these social determinants of health and how to interact with them. And I hope with some of the examples that I will give that I can illustrate how this model is very important in a lot of our centers to define their way of working. A last link to literature, I would say, is that I want to look at the Bible. If you look at what can we do about health inequities, how can we tackle health inequities, you unavoidably come across Michael Marmot. Sir Michael Marmot did incredible work in the UK on this topic, and which described these policy principles for tackling health inequity. I'll use this throughout the rest of my presentation to illustrate a little bit some examples from our centers, so I won't go into detail on this. I'll give you some time to read what he also described, and what I'll also explain in a further phase of the presentation is a working principle that's called proportionate universalism. That's crucial, according to him, to really, as a health provider, as a society, tackle health inequity. So this is a theoretical framework I'll use throughout the rest of the presentation to illustrate a little bit more our way of working. But first, I'll double check with Diederik. How is it going with some questions, some insecurities?
Yeah, there is a question from Jarne Gijsels. So is degree an indicator for income? Huh? And why do you use degree and not income
Okay,
if you talk
good
about
question. Yes.
inequities?
My honest answer will be because I'm trying to do this in a short period of time, but the question is relevant. Degree educational level is a proxy, a way to look at your socioeconomic position. Income is another way to look at it. So actually you can measure what's the social status of a person in different ways. Degree is one, income is one. Often they're related, but not always. So I think this is maybe something that's felt there. Indeed, the social gradient that I presented, and this is very important to know, is that you see the same pattern if you would look at educational level, you see the same pattern if you look at income level, you see the same pattern if you look at different diseases. So the pattern that you see there is very consistent in different ways of looking to socioeconomic status and different ways to look at health.
Yeah, okay, thanks.
Okay.
I have my own question, a little bit to provoke you, because why do you want to reduce risk? People want to take to have pleasure in their life, which makes them happy.
I don't know if I understood the question. Do
Well,
you want to repeat?
people take risks and probably they take them because they want to have pleasure in their life. And why should we
Yes.
reduce those risks?
Yes. Okay, so I assume you refer to risk behavior linked to health, which I indeed put there more as a way to look at healthy behavior, but it's a relevant question. I think unhealthy behavior for a lot of people working in care is a challenging one, because indeed people choose it often because indeed there's short-term benefits, and as a care provider you think there's a lot of long-term risks. I want to change your behavior. Sometimes people don't want to change their behavior. My point for sure is not that this is problematic per se. What literature does show, and what I want to point out, is that every person makes a balance between choices, and every person's choices are restricted by their social structure. Sociology talks about this as a balance between agency and structure. There's your willpower, your own decisions, and then there's what makes that you can make certain decisions. What's problematic and what we see in literature is that for people in vulnerable situations, often there's things in the structure, in the environment, that limit their freedom to decide. So if you fully decide to take risks, I think no problem. If there's societal things, social barriers that make that you can't really change your healthy behavior, I think as care providers, it's very important that we also look at these social determinants to give you the opportunity, if you want to change your behavior. Example, for instance, having people that eat very unhealthy, if they don't have an equipped kitchen in their house, if they don't have the means to buy ingredients, how can you expect someone to willingly really change their diet, for instance? I saw also a comment.
Fine. Yeah, there is a comment of Giel Bogart. Giel, do you want to explain a little bit about this, or will it come later?
No, it was just an addition about what Veerle was talking about the inequity. And the picture I posted was something that I frequently use when thinking about the difference between equality and equity. With equality, we give everybody the same care and the same access, but that doesn't help everyone as much because not everybody needs the same care and access. So the picture is in the chat if someone wants to see.
Yeah, see.
Nice.
Okay, then I propose, Veerle, you continue with your examples from the healthcare field, in mainly Flanders, from the community health centers in Flanders. Please.
Very nice. Thanks, I'll do that. So we'll dive into, I said here, our ways of working, do's and don'ts. To be honest, I mostly focused on the do's. I was feeling positive, so I thought I'll share some do's with everyone. I'll quickly go over this very short, but if people want to see, they can see it on our website or ask. We share a financing system, but we for sure with our centers also share a way of working. We have a concept of care that we try to bring into practice. And I'll point your attention to this purple building block, interdisciplinary care, topic of today. What all our centers share is that they work to different varieties, I would say, in an interdisciplinary way within their center. I looked a little bit on evidence on interdisciplinary collaboration, interdisciplinary care. I'm not a big expert. Maybe people here are much more experienced than I. I wanted to point out that I found quite some things on interdisciplinary working, improves access to care, care coordination, outcomes of care, but I didn't find so much on the effect of tackling health inequity. Does it work? Does it help to answer this health inequity in society? I think personally, my hypothesis is that there are some strengths in working interprofessionally that will help to take care of patients in vulnerable situations and to tackle health inequity. And I said I'll take these principles of Michael Marmot to illustrate this. Various of the policy principles put forward by Michael Marmot focus on social determinants of health. And I stress this, they focus a lot about giving a basic social security to people, a basic means of living, healthy working environments. And I'll illustrate a little bit how we do this in practice. So a lot of our centers focus very strongly on social determinants of health, try to offer holistic care that bridges care and welfare, and also take up a role that I think is very important but challenging for care professionals, is to take up some level of lobbying, trying to lobby for your patients, really try to make changes, structural changes in their life to enable them to live a more healthy life. All our centers have at least a GP. They all have nurses, and almost all of them have some form of welfare that they offer. Usually this is a social worker. And I'm not an expert in other contexts, but in Belgium, this is not so common that we have this integration of care and welfare within one practice. As an organization, this is something that we strongly recommend to practices, exactly because of the point I made above, the importance of social determinants of health. We think it's very important to bridge welfare and care to answer this existence of health inequity. What I wanted to point out a little bit outside of this presentation is that our teams will also usually include other disciplines, and which depends really on the population that they serve. Every center has a registered patient population, a clear delineated neighborhood around them that they serve. They look at a lot of common health problems, and then sometimes other disciplines are entered. But I wanted to look at this role of welfare and social workers in our centers. I'll just talk a little bit. So what's very evident, I think, is that already having a social worker and, for instance, a GP under one roof is tremendously helpful, because a lot of complaints that come in the consultation room at a GP, but can also be a physio, a nurse, whichever, have some basis in welfare problems, housing problems, problems that in a working environment. And so a lot of our centers offer individual consultation to deal with questions on administration, to help people change this welfare problems that they're facing. I wanted to pick out some examples that go more in depth. One is called Savoir, which is actually an example that also was going on in the practice of Dr. Giel that just took the word. He works in one of our community health centers. What they saw in this center is that indeed a lot of the questions at the GPs, for instance, they also had this, they needed the experience of a social worker. Plus, they also saw that usually it took some time before people actively ask help for these questions. Sometimes people accidentally stumble upon, okay, this person needs a social worker, but there was usually a lot of time before social care problems came to the social worker in the center. So what they decided as a center to do as a project is to proactively look at especially families with children, because of the vulnerability of children, and to proactively seek with these families, have you explored all the social rights, social benefits that you could have to help your situation? So if a care provider, a GP, a nurse, a physio in the center had an idea of, okay, here's a social problem playing, the patient didn't per se ask the question, but the GP or the care provider thought could be interesting, they would get a referral to the social worker of the center that explained to the patient, one, what are your rights actually as a citizen of this country, which social benefits that will help you respect these rights do you already access, but also which social benefits not yet, which could help you. And is it needed to refer these people to external social workers? I found this a nice example because it tries to really proactively look at welfare, also from a social right point of view. And I think it's also very nice to inform patients on what are your rights actually? What can you expect to receive as support? Another example that I heard when I visited one of the centers that I also found quite beautiful was in Brussels, in which the social worker here described that a lot of his patients that had disabilities came with him for questions about their file, about administration they had to do. What he did was the individual consultation. He would call the service, he would get information, then he would get back to the patient, explain. But all of a sudden he thought, like, this is actually not the most sustainable thing I could do. And he set up a collaboration with the federal public service that was responsible for people with a disability to have a kind of permanence. So once a week they would come to the center to talk with the patients themselves. This gave the ability to patients to access their own file, I would say, to have direct contact with the service that is responsible for the social benefit that they would receive. And I think is also a nice example of what he later described as trying to enable people to also take up what they can do for themselves. If you take the time to read the quote here, there's a beautiful description of you work with vulnerable patients. Sure, you need a lot of patience to explain, to listen. But it's also very nice to give responsibility to patients in a way that they can take up some responsibility, to support them to take this, of course, but to really not always take over the care, but to try to enable people to take some parts of their care process in their own hands. The fact that the service comes to the center, local center, of course, is very helpful for people in the community to be able to have this access to help. I wanted to see, Giel, if you allow me, if you would have some experience of working with social work as a GP. If you think about something, it would be for sure interesting to hear your point of view.
Can you repeat the exact question? Just
yes. As a GP, you work in a practice with a social worker. How is this for you? What's the benefit for you? Maybe also the challenge?
Well, one of the things that is very useful, and I wrote this down because I wanted to give the feedback later if you didn't touch upon it, is that the directly cooperation in the same building, it allows for much warmer referrals, is the term we use in Dutch, warme verwijzing. And which means that if you work together and you can give the trust that you get from the patient directly from the patient back to another colleague within another discipline, that makes it a lot easier for the social worker to get the trust from the patient, because we notice with a lot of socially weaker patients that when we say do this, do this, do this, they struggle with starting to contact someone new, because they don't know the way, they don't know how to ask for an appointment, they don't know how to say at the front desk, I need this. And if you can do it in the same building with direct colleagues, it really helps to address problems more easily as a team. And then you can point out, this is the problem, please colleague, help me with this.
Mm-hmm, mm-hmm. And I hope I hear also right, Giel, that you said in some consultations you would get the idea of maybe there's some social needs, but patients don't always come up with the question themselves, and then the trust that they have in you, if you say, okay, I have a colleague that's really good in this, it would really be good to see this person, that it's easier, there's less barriers to go through this welfare, no?
Completely. It's a bit naive to still use the old division between health and welfare, where a lot of medical problems are just welfare problems hidden beneath a health question.
Yeah. If we are now doing some interaction, Veerle, allow me to get some Austrian and UK representation and point of views. So first, Sylvia Wojciechowski from Austria. She has a question within a consultation. Do GPs use then a sort of a questionnaire or to determine the social needs, or is it just from out of the consultation itself that you see there are these kind of problems? Sylvia, I also would like to know if this kind of collaboration between GP and social worker is present in Austria. Can you say some words about this?
Yes, thank you. Hi. Well, in Austria, the primary healthcare sector basically now is changing a lot, but traditionally there's no interaction at all, actually, because there you have the GPs who are like the gatekeepers basically of primary health care, and so far the majority is still single practices. This changes now because there is a reform underway with primary healthcare centers, but I have to say in most cases it's still a focus very much as the colleague just said of like a traditional health perspective. So it's health professions and social professions are still lacking. So it's very good and very interesting for me to listen to this talk, because I also believe that obviously it belongs together.
So your question, Veerle.
You can, of course, also correct me if I'm mistaken, but my answer would be that in most practices there is not a standard questionnaire that is used by GPs, but that there is in quite some of our centers a systematic intake. So if you have to subscribe in a center, and that then there's some social information that's already gathered. I see some nodding on the side of Hugh. I don't know if you want to add something, Hugh.
Yes, at the intake, there is some information that is gathered, but the question is directly asked to the patient who is having the intake. Do you need any help with any social problem? And at that time, it is possible to have a direct referral. We don't need a referral from the GP. Any patient can ask an appointment with the social worker at any time, and then they will see what they can do. The other possibility is indeed during a consultation, a social problem comes up, then we do the referral ourselves. Another possibility, more from the project that we did earlier that Veerle was also talking about, the Savoir project. That was when we really tried to pick out the more vulnerable patients, young parents with young children from whom we fear that have social needs, especially single parents. Those were patients we referred more actively.
Okay, thanks. Ken Eaton, would you like to comment?
Yes, I'm unmuted now. Thank you very much. Really, this hasn't developed very much in the UK, I'm afraid to say, in spite of all Marmot's work in the past. But I strongly agree with co-location, and it should be that when a new medical practice opens, there's sufficient to have the social workers there, the nurses, the physiotherapists, the pharmacists and the dentists as well. So they're all in this hub together. And I think another point is we really must push to have integrated health and social care records so that with the patient's permission, any health provider or social worker can access and get the big picture of what the patient's problems are. And in that particular area, there is a survey coming out, and I will contact you, Dietrich, about this, because I think it would be very helpful if the society could get involved in it. Thank you.
Thanks. Veerle. continue
to
with your
hear.
presentation, I think.
Thanks. Yeah, and maybe just adding maybe one reflection on our interaction. I wanted to, even though I find that we have some value in already integrating social care and healthcare, I want to make clear that we actually use money that's given for us to provide care, to provide GP care, and we take a part of this to pay our social workers. So we go a little bit in the gray zone in the sense of financing, which also makes that the amount of social support we can give is more limited. So we also operate in a context that's not very supportive to this integrated care. Can if I can call you can at least.
Yes, yes.
I totally agree that there's a big way forward, and we feel that this also the division in financing is very challenging to make this happen really. All right, I'll look further to what I have in store for you still. I also wanted to draw the attention to health promotion. So not only to look at curative care, but to look at preventive care. Michael Marmot talked about the prevention of ill health, but within our sector, we usually talk about health promotion, which is a more positive way to really enable people to lead a healthy life, how they want to live their life, of course. Within our vision, we state it as a task for the whole team, but most of our centers have one coordinating figure. I call it like this, a health promoter, we call them. And often this is possible through collaboration with local government. And in a lot of our centers, this collaboration with local government with a little financing is very helpful to take the functioning of the center even, I would say, a level up. So here I have some examples. I think to really look at tackling health inequity, it's important to also go beyond health education. I mean, only giving information sessions to work only on increasing knowledge of patients about health behavior, health promotion, and to also look, as I said, at these social determinants. It goes a little bit into the conversation I had with Diederik about, okay, people make unhealthy choices. Do they have the right to make unhealthy choices? Of course, but only working on knowledge and not looking at the structural things that people need to make behavior choices is actually detrimental. And literature shows that having health promotion only focused on knowledge and on strengthening knowledge of patients is leading to higher health inequity, because people that will be able to change their behavior will change their behavior, and often these are people with a stronger socioeconomic status, while a lot of the times more vulnerable populations won't be able to change behavior even though they have the knowledge. So it's very important to link working on knowledge in patients in looking at what are barriers they perceive to change behavior. As a little example, you see on the right a report, it's in Dutch, that was written by one of our centers, which looked at movement, sporting activities for children, specifically in their neighborhood, because they see a lot of children with obesity, but they also see that quite some families have difficulties accessing sporting facilities, for instance, clubs. They see a lot of barriers, and these barriers are really not only linked to being able to pay, but it's also psychological barriers to go there, a lot of different barriers that they encounter. So what they did was talk with patients, but also with local partners to together look at what is happening here, what are barriers to really go into a movement, exercise, sports for children in our neighborhood. So I said there also as a way of working, very helpful if you work on health promotion to collaborate with local partners, social partners, the local policy level. Very strong point as well, I would say, is to know your population. And in this sense, I think we have a strength. Usually GP practices in Belgium don't have such a strong delineated neighborhood that they're responsible for, and don't have a fixed patient list. People don't register with a GP in Belgium. There's a lot of freedom to go to a GP where you want. Our centers have a list of all the patients that are inscribed and have a very clear regional part of the city that they're responsible for. So knowing who is my population is already very important, to know which are important problems that occur within this population. And one final example I'll give on this specific point is, for instance, again, in a center in Brussels, they saw a lot of problems with moist, damp in housing. So they did work on health education, increasing knowledge of patients about this, but also did this with social partners that could help people that wanted to, that needed help to, for instance, talk with their rent, with the house, the landlords. They involved patients even in the sense of making them co-ownership about the workshops that they were developing, so that all of the examples were given by patients from the center, which created a very nice dynamic in an information session. You work on knowledge, but you do it in a way that's very inclusive, I would say. I had a video about this, but I'll skip it. But maybe you can look at it at a later point in time. With these last minutes, I would maybe talk about a very important working principle, the idea of proportionate universalism. I assume a lot of people already heard about this principle, so I repeat, it's what was put forward as a way of working that's really helpful to tackle health inequity. And basically, the easiest way I try to explain it usually is to compare it with when you learned how to read. In Belgium, we learn how to read like at 6-7 years old. Imagine that we expected that a teacher would teach you how to read one time, and then would expect that every child would have the same level of reading. No one expects this. In a class situation, it's very evident that you have extra support for children that have difficulties reading, for instance, that you have some differentiation. However, within care, we often have one way of working that we expect all our patients to fit into, the same level of support to all our patients. And this goes into a comment that Giel also made. Doing the same thing for all your patients isn't helpful if you want to tackle health inequity. Proportionate universalism talks about giving extra support to people that need extra support, extra attention to people needing extra attention, to have equal, equitable outcomes of care. So, for instance, I'll focus on the last point that I have here on my slide first. Very little examples that you can show this. Often our health promoters have group sessions in which they try to unite some patients with specific problems to, for instance, talk about their mental health. Sometimes there's very vulnerable populations within these groups. People that have very acute mental health problems, but also people that for some reasons are not very good in time organization, for instance. Usually centers know who these people are that can need a little push, and they get individualized a phone call or a text message as a reminder to come by in the session. We don't always do this for all the patients, but for patients that need an extra push and extra support, often our centers try to offer this to make sure that people who need some extra support get to the care that they could use. A more formalized way in which we fill in this idea of proportionate universalism is by working with intercultural mediators. Quite some of our centers, not all, have specific functions, specific people that work on mediating between people with a different, that don't master Dutch, from specific ethnic subgroups, and the staff. And this mediation takes the form of translating, which is sometimes very needed, but also takes the form in trying to bridge potentially cultural gaps, trying to inform teams how to work cultural sensitively. It's a difficult word to pronounce, but I think I get the message across. Different of our centers already invested in with own means in such a position. We also had some project funding by the government to have specifically people that work with cultural support and a language support to include people that don't master Dutch, for instance. Also a way to look at people that need extra support to reach care. I'm coming towards potentially the last of my examples, but then we have some more minutes for exchange, and I'll maybe finish with these. I thought for myself about some challenges that pose themselves. One goes further on what I just described on these intercultural mediators. Quite of our centers are usually seen as, in Belgium, as experts in accessible care, which is a very nice compliment. However, what we see is that sometimes we're also seen as caring only for very vulnerable populations. Very specifically, for instance, in some regions, we see that GPs that have a new patient that come in, they don't speak Dutch, they need translation, they get the message, okay, I don't use a translator, but this community health center does, so you can just go there. Which in my experience would be problematic, but I would like to hear maybe your points of view on this.
Sorry, you ask now for all of them, all of us?
For whoever wants to have an interaction, for sure.
Yeah. Okay, floor is open. Well, the issue here is, I think, is very much Veerle made a comment on the comment of Ken, and is mainly focusing also on market forces in healthcare. And if you look at the first one, well, if you the market forces will never give attention to vulnerable patients. It doesn't pay off. So if you organize it in such a way that only this kind of initiatives will take care of the vulnerable patients, and you leave market forces into the system, then it will have no end. That's my point of view. But maybe there are other. There's.
Maybe I can already give a reflection also that what I also see is that for people working in our centers, it's fulfilling to take care of vulnerable populations, but it's also not doable to only have very vulnerable populations in your center. This is very emotionally draining. It requires too much energy, I would say. But also, ethically speaking, we do not want to have a care system only for vulnerable patients. This is really not something that I would have as a societal view, that we have a specific system for people that have some problems or some extra need for support.
Yeah. Well, there is in fact a question in relation to this, Veerle, but very simple question, I think. Do you also offer psychological support for mental health problems?
I would say to some extent, especially now in Belgium, there's a new legislation that through which there is funding for what we call primary care psychologists, and quite some of our centers offer a place in which these people have their office. This would be my answer, but I see that maybe Giel also wants to react.
Well, the problem with the new policy is that it doesn't meet the need for psychologists that are easily accessible. We've noticed that with every new psychologist that come to this way of working, the accessible primary care psychologist, that within 2 months their agenda is completely booked for the next 6 months probably. So there is a huge amount of demand where there are too few people that want to join in this idea, this way of working, and I'm also afraid that the national stimulation for this way of working is not enough.
Yeah.
I agree. For sure.
There is the response of Jarna Gijsels, and I would like to give you the floor also, but First of all, so is there anything in the pipeline to address this issue in the pharmaceutical dentistry business on a policy level? But I think, as I said just before, it's not related only related to pharmaceutical and dentistry. It's related, and I hope, Giel, you agree with me. If you let market forces enter into this kind of services, it will create a very difficult situation in every care you want to provide. So I think for me it's always a clear example. Don't have market forces within your system. But Giel, tell me if you disagree. But
no, of course not. It was also very clear that a few years ago, before current health minister, there was a minister of the blue liberal color who made very lucrative deals with the pharmacy industry, but where the health was not involved in the whole discussion. So it's always about the money with some political ideologies, which cannot be allowed in some industry. Health is one, public transport is the other.
education.
Education.
Yeah. What I'm curious about, you discussed the interprofessional collaboration in relation to health inequity. I think indeed putting people under one roof, it reduces the barriers between the professionals. It's clear that they have better communication between themselves, but there is also the choice of vulnerable patients to choose for the provider which has the lowest threshold from his or her point of view. That adds already. If you don't have such a good relationship with your GP, but your physiotherapist is a wonderful person, and you can, that helps as well. All this, is it already presented to in the educational system of professionals? Because I think those professionals who are now in training, they should be aware, they should be trained that this is one of the added values of such system. And that might bring it further, or not.
I can talk a little bit about how it's done in Ghent, but I see there's also a reaction. Maybe I'll wait if there's.
If Rose Ventura wants to react, please join the discussion.
Hi. Yeah, I'm Rose and I'm a nurse, but when I was training as a nurse, I did have the opportunity to make practices at a medical house. And it was very interesting. I did like it a lot because of the multidisciplinary working, but it was also we worked a lot on this point, that was that the view of people or patients was that only vulnerable patients were welcome with us. But actually, we encouraged other patients with less healthcare needs to register with us because of the specific capitation system. So if the more patients we get, the more budget we have, and the more we can help vulnerable patients. And I think that this also helps to tackle the health inequity because we can care more for those patients. But there was this misconception, as you say, that only vulnerable patients were welcome with us. And this is actually a very shared view within the community in Ghent, at least.
Yeah, indeed, I can imagine. And I think you put a point that's shared by a lot of people that work on our practices. It's not desirable nor doable to only have very vulnerable patients within our centers. We want to have people that live in the neighborhoods, and that's a social mix within our centers. Also for care providers, usually it's really much more rewarding to have a mix of different profile of patients. So it's important for the well-being of our care providers as well to go for this. If I can answer on your question on educational system, Diederik, very quick, maybe to, I don't know if it would be the last remark. In University of Ghent, I know that there's in different curricula for medical and paramedical professionals, there is attention to go into social determinants of health. I know in the medical curriculum, it's in different years. We have a course on community-oriented primary care, which helps. I see rising attention, at least in our university, on diversity, meaning socioeconomic diversity, cultural diversity. So in that sense, I am quite hopeful with what I see in our own university. I think it's of utmost important indeed that people are trained on these aspects, and indeed, as you say, interdisciplinary working. And also there I have the feeling that within our educational system, there's more and more attention to it. I see, compared to when I was trained, this was not in my training at all. And I think it's very important if we want to train a workforce that's ready for the future to really embed this in training as well. And there's quite some projects running at university level.
Yeah, no, I cannot agree more. And I think I might say then to conclude on this session, Veerle, thanks a lot. But for me, there are three key messages. Do not mess around with market forces. I think patient lists, a defined patient group is key for a good provision of healthcare, and make sure that those different professions working in primary care do know about each other's talents and added values, so you can profit of it and patients can choose their own way of getting entrance in the system. That would lower the threshold a lot. For me, those are the three key messages. I don't know if anybody wants to add something to this. If I missed something crucial, please tell us now before we're finishing. Then indeed, I thank you, Veerle, for and Giel also for your very good contributions as well for this webinar. Allow me to give some more advertisement for the next webinar. So on the 7th of December, Erik Bischoff from the University of Nijmegen on chronic care issues, and on the 14th of December, a webinar on the young professional workforce in primary care and how to keep ourselves strong. Thanks a lot, and very nice day for all of us. See you. Bye-bye.
Thank you very much.